malabo. Malinaw.
We can start as you okay, no?
Diyan na si Claro.
Wala pa si Claro? Si Claro pa lang, wala pa.
Nandito
I'm
na
here.
daw.
I'm here na po, Doc.
We're just waiting for Dr. Panaligan na lang po.
Doc, pero mamaya pa si Dr. Panaligan, nahabol na lang. So, we will start na with Dr. Ina.
Okay po. Sige po.
Thank you, Jeff. Kita ba, Jeff? Ikaw, sumisilip ka, ha? Kita pala. Sorry.
It's okay, Doc Sam.
Hindi ko mapalitan yung
Yung background mo, sir?
Background. Actually, hindi gumagana yung ang video ng ano ko.
Baka from yung sa specs nung laptop or ng device?
Yes. Mukhang luma na yung aking laptop. Yung
Apo, sir.
Yung MacBook ko. 2012 pa eh.
As of now, sir, we have 253 participants.
Wow, dami.
Sir.
We can start na siguro, okay?
Okay, sir.
Oo.
Alvin, kindly flash yung house rules natin. Sir, you might wanna run through the house rules lang po quickly.
Ako na?
Yes, sir. Apo. Alvin, kindly flash yung house rules. Thank you.
Siguro doon na sa introduction yung Kay. Pag sa introduction, I will introduce the house rules introduction.
Okay.
After
Sige
the
po.
program.
Apa. So let's all start with a prayer. Let us all put ourselves in the presence of the Lord. Heavenly Father, we praise and thank you for giving us today, for all the things that we will learn from our speakers and colleagues. May it be of help to others who are looking for answers this time of pandemic. Let it be light, hope, and cooperation amongst our leaders, scientists, healthcare providers, and all who are instrumental in overcoming this crisis. In Jesus' name we pray. Amen.
Amen.
So for the first part of our program, an introduction to this webinar by Dr. Samuel Erastorasa. He is the head of the UERM Alumni Webinar Committee. For this webinars, he's the driving force of the UERM alumni. So, sir.
Thank you very much, Kay. Can you please flash so this will be our 5th webinar, and for those who have been following our webinars, you already know our house rules, but for those who have just starting to follow us, to watch with us, okay, here are the house rules. So first of all, everyone must turn off must unmute their cell phones or their laptops. Can you turn off your videos? Our moderators will also turn off your sounds and your videos should they be on accidentally. Also, if you need some questions, if you need to post in some questions, just write it in the chat box, and our moderators will read them for you during the question and answer portion. So we'll start off with the lectures of our speakers. Then after that, we will have the the question answer portion. Of course, please observe proper decorum, and of course, enjoy the webinar. Thank you.
So for our moderator today, it would be Dr. Claro Raimundo Antonio. So let me introduce him first. So he's a batchmate of mine, a graduate of the class 2007 of the UERM College of Medicine. He finished his internal medicine residency in UERM, fellowship training on infectious disease and tropical medicine at St. Luke's Medical Center, Quezon City. Currently, he's an assistant professor of the College of Medicine, UERM, the head of the section of infectious diseases, and chair of the Infection Prevention and Control Committee of the Providence Hospital. He's also an active consultant of St. Luke's Medical Center, Quezon City, and a fellow PCP and PSMID. So good evening, Dr. Antonio.
Good evening, everyone. Can you hear me?
Yes, Claro.
Yes.
Hi.
Claro, Claro.
Yan, klarong klaro. Good evening, everyone. So for this, for tonight's webinar, I will be the moderator. So I will facilitate the questions. So we have ways of, if you want to pose a question, there are ways for you to ask the questions either through chat box or Q&A. We will also be posting this as FB Live and on Facebook, so you can also post your questions there. And then later on, after the two speakers have done their talks, we will open the floor for questions. If you will address kung kanino nyo ibibigay yung questions, like to Dr. Racolaico or Dr. Panaligan, so that we can facilitate ng maiging ating line of questioning, right? And for tonight, we are privileged to have with us two distinguished speakers from two different societies, although they are both infectious diseases. One will be the update on the management of COVID infection, and one will be the update regarding infection prevention and control. So for our first speaker, would like to introduce our first speaker for tonight. She is also currently, she is the Vice President of Philippine Hospital Infection Control Society, or PHICS, and also currently the President of the UP-PHICS Society of Infectious Diseases Alumni, or UPSIDA. She is also a fellow of the Philippine Society for Microbiology and Infectious Diseases and Philippine College of Physicians. Her hospital affiliations include Our Lady of Lourdes Hospital and the San Juan de Dios, wherein she is also the head of the section of infectious diseases, the chair of the Hospital Infection Control Committee, and the HIV/AIDS core team of Our Lady of Lourdes Hospital, and the co-chair of AMS at San Juan de Dios Hospital. To discuss about updates on the infection control in the hospital setting, in the setting of COVID-19 infection, let us welcome Dr. Catherine Amalia Clemencia Colaico.
Good evening, everyone. Let me just share my. Yeah, good evening, everyone. I've been asked to share or to speak on the updates on prevention and control of COVID-19. This lecture will keep it short. We want to spend more time with management later on, because I know there are already advanced questions that are going to be asking or have been asking about management already. No, so basically, we'll talk about prevention of and control of COVID in the hospital setting. And generally, the principles of IPC, or infection prevention and control, should apply whether we're in the hospital setting or outside of that, no, even in our home. So we will just give you the very basics of IPC, taking into account also that many of our listeners are probably practitioners also in areas where there are limited resources. So hopefully we can address some of those concerns later on. So let's just review, the issues that we have with regard to with regard to COVID-19. Remember that in the implementation of protection, it always depends on the infecting organism. No? So infection or transmission of infection is dependent on the host, the environment where the infection may potentially happen, and of course on the infecting organism. So what is important in terms of this virus, is that it has presented largely with respiratory symptoms. And so as a review, when we look at respiratory infections, we remember that these can be transmitted through droplets, which can be of different sizes. So you may have droplet particles that are greater than 5 to 10 micrometers, and these are what we call respiratory droplets. When the particles are less than 5 microns in diameter, these are referred to as droplet nuclei. So droplet transmission generally occurs when a person is in close contact, which means that's within 3 feet or 1 meter, with someone who may have the respiratory symptoms. And when we say respiratory symptoms, these are symptoms where there is propulsion of the secretion. So patients who are coughing, who are sneezing, maybe who laugh out loud, no? And there is the risk of these droplets to infect or to enter the recipient's mucosae through the mouth or the nose, or through the conjunctiva of the eyes, exposing them to potential infectious agents in the droplets. So transmission may also occur when it's droplets through fomites in the immediate environment. So that means because the droplets are heavy in nature, when they land, wherever they land, these can be sources also of the infecting organism. Airborne transmission, on the other hand, these refer to the presence of microbes within the droplet nuclei. So these are generally considered to be particles less than 5 microns in diameter. And because they are lighter than droplets, they can remain in the air for longer periods of time, so that these may be transmitted to others over distances greater than 1 meter or more than 3 feet. Can I be heard? Sorry.
Yes, Doctor.
Yes, po.
Yes, Doc.
So what do we know about SARS-CoV? So the current data suggests that person-to-person transmission is effective and efficient, and it most commonly happens during exposure to an infected person, primarily by droplets, respiratory droplets. So transmission may also, however, occur through contact with contaminated surfaces, and then this is followed by delivery of these organisms or the virus to the eyes or the nose or the mouth whenever we touch our face. Airborne transmission from person to person, which has been reported in some cases, is not likely in terms of COVID-19 or of the SARS-CoV-2 virus. It was said in an analysis of 75,000 plus COVID-19 cases in China, they were not really able to document airborne transmission. However, the contribution of small respirable particles, or sometimes called aerosols, or the droplet nuclei, can also infect in close proximity. So they may be able to transmit. However, this still remains uncertain. So in the context of COVID-19, airborne transmission may be possible in specific circumstances, wherein there are procedures or treatments, supportive treatments, that may generate aerosols. So this may include intubation, bronchoscopy, open suctioning, the use of nebulizing agents, the manual ventilation before we intubate, no, the bagging, and then applying BiPAPs and all of these, tracheostomy, and then of course performing CPR. Now, so these are procedures where potential aerosolization may happen. In such case, the droplets go into the droplets go into the air, no, and are carried in the air nuclei, or the droplets in the air, and may be aerosolized and transmitted further through apopulsive action. Some reports have reported finding the virus in diarrheic specimens. So it was proposed that this can also be a form of transmitting SARS-CoV-2, just as it was reported for SARS-CoV during the SARS time in 2003. In general, though, the virus is shed in significant amounts and thus is communicable more when we have signs and symptoms of illness. So again, these signs and symptoms of illness are more often than not respiratory signs and symptoms. Now, there is reportedly a brief period, about 24 hours prior to the onset, wherein the sick individual may also be shedding the virus. And this is believed to be, during that time, not very significant as compared to the time when they are actively showing already signs and symptoms of the illness. So when we talk about control of infection, we have to take into account again how this is transmitted. So we said it's droplet transmission of a distance of 3 feet. However, it can be potentially aerosolized, and it can also infect the environment and result in transmission via contact through fomites, and then of course through our hands. So it's important in the control of COVID. We're seeing that we're already I think in our fourth month into this infection, and we're still seeing numbers of patients coming into the emergency room consulting with symptoms for COVID-19. And so it's very important that all health facilities are in fact prepared for this. And I'm sure you all know this already, but again, just the very basics that we always have to go back to is that the health facility must always have an organized ICC, a point person or a point committee that will oversee all the processes related to the screening of patients, the triaging of patients, diagnosing them, and managing and the disposition, especially patient placement, and how to handle all the aspects of the infection. Remember that it's not a perfect science. We've seen changes, we've seen different patterns in different areas of the hospital, and so time and again, all policies should be reviewed, and this is done by the ICC. Again, we all know this already, but just to reiterate that a special triaging system must be in place. And if your triage system is failing you, meaning to say, marami pa rin nakakalusot, patients who are not properly screened for signs and symptoms, then again, all of these need to be reviewed with your healthcare workers, with administration, what works better, what should not be done anymore. So again, when we say triaging, it includes a system for assessing all patients, as well as the visitors, which we try to limit at this time, companions of the patient, the family members who present at admission, and then allowing early recognition of possible infection. And then when we, of course, identify those who are potentially infection or potentially cases of COVID-19, then the immediate isolation of these patients in an area separated from other patients. And this applies to both the emergency room, outpatient services, or wherever you have set up your triage up to the time when the patient is admitted in the hospital. The hospital should also ensure that there is always a reliable mechanism to ensure stocks of materials for hand hygiene, and for personal protective equipment for the healthcare workers. No? It can be very frustrating sometimes when we see that alcohol dispensers are empty and wala daw stock, no? Or because sometimes the hand washing facilities are not um, easily reachable depending on where you set up your triaging system or where you receive patients. So always make sure that wherever you are seeing patients, whether they are COVID or not, but more especially when you are assessing them, that you have access to hand hygiene facilities, whether it's water and soap or your hand rubs, no, your alcohol-based hand rubs, then that should be uncompromised. So when we say on effective triaging mechanisms, we also have to ensure that the place where we see these patients have adequate ventilation. Again, while these are droplet spread, when there's one patient coughing, these can be essentially aerosolites. So you all know that if you can, we advise that you provide masks for your patients consulting when they present to you without one. You know, just to make sure that should they cough or sneeze or generate any aerosols, that you have a mask there that serves as a barrier. Always ensure that the area where you are receiving these patients has a adequate ventilation of 12 exchanges per hour. The minimum is really 6, but we advise 12 for adequate prevention, especially when we have potential aerosolization. Now, the distance between patients, as we mentioned, is dependent on whether these are droplets, heavy droplets, or airborne. So we usually advise at the least, or at the very least, 3 feet. This is for standard droplet protection or prevention. But if you can manage double that distance, that would be better for the potential aerosolization. Now, wherever we see COVID patients, no, it should be safe, and we should at least once we see them, maybe even the triaging area, isolate them already, even at the emergency room alone. And the ideal really is to put them in single rooms. If that's not possible, then yes, if there is no choice, then cohorting these patients with observing proper distances is recommended, or may be done. However, you run the risk of mixing your true positives and those who might turn out negative in the test. And if your room is air conditioned, then the air system must be, or the air conditioning system and ducts must be isolated, not a centralized system of air conditioning, so individualized as well. And as we mentioned, you want an air exchange of about 12 exchanges per hour. Now, there was earlier on when we were dealing with this, we were always talking about negative pressure rooms. And negative pressure rooms are really ideal for, especially when we talk about airborne transmissions. So some of these airborne transmission infections would include TB, varicella, measles. In that setting, of course, it would be the best scenario. However, it is not required for COVID areas. As long as you're able to enable or work with your engineering staff to enable 12 air exchanges per hour, then that should be adequate enough. Now, ideally also, you want to limit the movement and traffic flow into your rooms where you have COVID patients. And sometimes that might not be very efficient, especially when in an ER setting, when there's just so many people moving around. So, but ideally, when you put them in a place that is confined for them, then you only want your essential healthcare workers entering these rooms. So these are those who are assigned to attend and trained to attend to your COVID patients. And you want to keep to a minimum those who come into the room, including your housekeeping staff, your laboratory staff, your X-ray technicians, cardiology technicians, all of these. You want to limit that and dedicate a staff member to attend to these cases. And of course, once a patient is truly confirmed to have COVID-19 through your RT-PCR, then you want to manage them in a individual single room. So this is just a table that gives us a rough estimation of the air exchanges that maybe that you have in your different settings. So if you will notice, the one we said we want a minimum of 12, ideally 6 to 12, but ideally for airborne, you want it even at 12 to 15. So if we're going to look at your table here, you will note that probably the one with the highest air exchange really is are the rooms with open windows. So if some of you attended that webinar by Dr. Seto and the WHO about last week, he kept saying that the open window gives you really the best ventilation, because that's even the recommendation for TB control in especially in hospitals where there are limited resources. So completely open windows and closed doors gives you this air exchange. If you have just an open window without without the exhaust, then this is it. So generally, the ideal really is to have the windows open for these cases. Now, it's understandable that many of our hospitals will have air conditioning, and in which case opening the windows might result in breaking down of the system. So in such cases, then maybe exhaust fans are going to be the best option, where these are the scenarios where you can't open your window in the presence of a COVID patient. Now, let's move on to the isolation precautions. So we talked about, again, we want to go back. What is your infecting organism and how is it transmitted? So we said it's spread largely by droplet particles, but it can be aerosolized. So the very basic is standard precaution. This goes for all kinds of infection. And the pillar really of standard precaution is hand hygiene. And for those of us who practice infection prevention and control, you'll never stop hearing us say or talk about hand hygiene, because really it is the single most important infection prevention method that should be practiced, that should be second nature to all healthcare providers, whether you're a physician, a nurse, a midwife, it should be standard. And healthcare workers should know how to perform hand hygiene. You can use this with your standard soap and water, especially if your hands are soiled. Otherwise, you may use alcohol-based hand rubs, and these should be used, and hand hygiene should be performed before and after each patient contact. And also when you contact or you have potential contact with infectious agents, infectious environments, before you put on your PPE, after you put on your PPE, or when you remove it, even when you wear your gloves, hand hygiene should be observed before and after donning your gloves and doffing your gloves. It should be performed in a minimum of 20 seconds. I've seen doctors even now with COVID who just run their fingers under the faucet and a bit of soap and then dry it up. No, that will not work, because the minute your hand touches your face, which we don't want you to do, then you can potentially infect yourself, not to mention infect those around you. And there's a false sense that you washed your hands. So when you do wash your hands, make sure that you observe doing it properly. You cover all sides of your hands and fingers and try to or aim for 20 seconds when you wash your hands or when you perform hand hygiene. And then, of course, because we talked about droplets, then we also want to practice contact and droplet precautions, especially before we enter patients who are COVID suspects. So contact precautions, these prevent direct or indirect transmission from suspects or those confirmed COVID patients, and or contaminated surfaces. So when you contact with contaminated oxygen tubings and all of that, these are things that you want to make sure that you protect yourself. Again, when we do contact precautions, you're protecting yourself, no, not the patient, and you're protecting yourself from infecting others as well. So basic contact precautions will include using your gloves and your disposable gowns or your isolation gowns when disposable gowns are not available. Now, droplet precautions, on the other hand, again, we want to prevent large droplet transmission of the respiratory virus. And these will include your medical mask or your standard surgical mask and your eye protection. No? So by the means of goggles or a face shield. Again, we said that transmission can be through your mucosae or your conjunctiva. Now, if you are working within 1 meter of the patient, again, this patient is not actively aerosolizing, and your patient may or may not have a mask, then you want to make sure that you're wearing a medical mask. Ideally, when you're going to be talking face to face with your patient, whether or not this patient is wearing a medical mask himself, you want to be able to protect your eyes, and therefore we do recommend wearing eye protection with goggles or a face shield when you see your patient. When you examine your patient, as much as possible, try to keep a distance of 1 meter when you're seeing your patients. But inevitably, there will be cases where, of course, when you finally auscultate your patient and all and check for your pulses, then you can't really keep that distance. Make sure there is no, or you try to avoid face-to-face contact or exposure with your patients during these patient encounters. Now, in particular, the use of PPEs for contact and droplet precautions should be performed when entering the room, and they should be removed properly before leaving. So now, in isolation precautions, again, because we're talking about contact precautions, ideally the equipment that we use for our patients should not be shared. Ideally, we use dedicated equipment for every patient. So that would include your VP cuffs if that's possible, your stethoscope. However, if the reality is we can't really provide individual VP apparati for our patients and stethoscopes. So you want to clean and disinfect these between each patient use. And very effective in these is the use of ethyl alcohol. Now, it's also very important that when we see our patients, we always disinfect areas where there is high contact. So the door knobs, door handles, light switches, bed rails, and all of that. And it's very important to refrain you from touching your eyes and nose and your mouth. Apparently, one of the reasons given by CDC and WHO early on when COVID-19 was starting out for wearing masks is that it should prevent us from touching our faces. It should inhibit us from touching our face too frequently. But sometimes we make the mistake also of adjusting our masks a lot, and touching a potentially infected area with our bare hands. That's why the hand washing, especially when you touch your face before and after that, you have to perform that. Again, you are protecting yourself from infection. We mentioned this already, applying airborne precautions in aerosol generating procedures. And so when we say airborne precautions, these are unlike droplet precautions where we use maybe just a medical mask. In airborne precautions, we want to use higher or masks that will with greater filtration. So use the appropriate PPE that will include using your gloves, your long sleeve isolation gowns, using your eye protection, and very important, your fit-tested particulate respirators such as your N95 or the equivalent of such, which would be right now we're seeing a lot of KN95s in the market, and that's really what is being provided for many of our hospitals. And then of course your FFP3 and your FFP2, which is the minimum requirement. And whenever possible, use adequately ventilated rooms. We mentioned this already for your airborne precautions. And very important to avoid the presence of unnecessary people going into that room. No? I saw it in one hospital, an intubated patient, and the housekeeping staff was apparently new there, and he just goes in and does his thing without heed of the intubated COVID suspect, and that's really a no-no, and that was a reportable case for that. So the issues on personal, on PPEs is not so much um, uh, what do we use, no? There's a lot of fear, especially I've seen it in our hospitals where nurses who see COVID positive patients are so worried because they were only wearing a medical mask, no? When in fact, when you do the interview and when you ask them, the patient was not aerosolizing, wasn't even coughing, wasn't even febrile, no, and the contact of the nurse was really just a short time. She just came in, checked the IV. So again, it's not so much that we are not protecting ourselves. We said that the medical mask is the minimum, no, unless these patients are truly aerosolizing. But what is important is the proper donning, really, of the PPEs. And I think what is very important is the proper disposal and doffing off of these PPEs. No? I don't know how it is in your hospital, but in both the hospitals I practice, I've just been seeing so many nurses and residents and walking down the corridors in their overalls, no? and then doffing it improperly. Again, these are practices that we really do not want to encourage. I don't know how it is in your hospital, but these are practices that we don't really want to encourage because it gives us a false sense of security or protection when in fact we might be infecting ourselves by the practice or the poor practices of donning and doffing. So these particular slides are really just WHO slides that show us the proper way really of donning and doffing of our PPEs. And you will notice that in between each step, really, your hand hygiene is very, very important. Notice on the upper part of the slide also the proper donning also of your medical mask. No, that's another thing. Sometimes, again, as I mentioned, sometimes we often just touch the front of the mask, and when we pull it off out front instead of taking it off from the ear lobe as it should be done. No? As you will see on the lower part or on the lower part of the slide. Now, what is this? For PPE, for aerosol generating conditions, you will now need to use your respirators or your N95. And it's very important. The ideal N95 really should be fit tested, no? And you should really have it secured, preferably behind your head. Now, we do have KN95s that are locked behind our ears. And if you test the fit, they really don't fit very well. Like, again, I don't know if these KN95s come with sizes. So if you can provide yourselves with ear protectors or these gadgets you put where you can hook the loops of these masks on and give you a better fit, that would be more ideal, no, in these cases. Now, when you wear your PPE, especially your N95, the ideal really is to fit it, to make sure that it is sealed properly. And these are just the general steps. So we don't just put it on. I've seen many of our residents wearing a very large mask, and it's really fearful because they attend to COVID positive patients and they're wearing masks that are too large for their faces. I saw a doctor in the emergency room and his mask was too small for his face. And again, you want to make sure that your mask fits you and gives you a proper fit, you know, that you can still breathe also when you have it there, you know, especially if you're entering a COVID ward or several rooms where you don't really want to be removing your mask or adjusting it all the time, make sure it's fit properly before you move in. And here are the different steps that you can use when you perform your seal check. You want to cup the respirator in your clean hand with the nose piece at your fingertips, and then you allow the headbands to hang. And then when you position it first under your chin before you bring it up your nose piece to the bridge of your nose, and then you pull on the straps of your mask. No? And then once it's in place, then you mold the clip or the mask on across your bridge, no? Preferably using two hands. If you use one hand, sometimes the fit isn't very well. And when you also cover, and when you want to test now whether it's fit well, you cover the respirator, no? And then you carefully inhale or inhale, making sure that the seal is well fit. No? If it fits well, then when you inhale, there should be a retraction. Most of the respirators will do that. And there's a positive pressure when you exhale and there's no exit around. If you are wearing goggles or glasses, the minute this mists over when you exhale, then there's a leak and you have to go through your fit testing again or fit the mask properly again in such cases. Now, many questions have been raised about the reuse of PPE. It's a real problem. It's a real problem, especially those of the use of masks. This has been not only a problem for the Philippines, but also WHO has also mentioned it as a problem already in worldwide, and we are looking at several more months of this happening, and we really want to be able to preserve our PPEs. So many of us reuse our respirators, I know that. And so generally, respirators can be used within the design specification for 8 hours or continuous intermittent use. And the maximum length of continuous use should be based on your manufacturer's recommendation. Now, if the N95 were to be used, should we reuse it or extend its use? No, the Asia Pacific Society of Infection Control really generally recommends extended use rather than reusing. No? So when we say extended use, if you will be seeing several patients within the day of COVID positive cases, and there you have those who are both intubated and those who are not, then you can use the same respirator when you see one patient after the other, making sure you see your aerosol generating patients last. And you can also extend the use by covering the mask itself. So if N95 will be used for an extended time, then these respirators must maintain its fit and function. So kung UP na siya, if it's already dented, if it's already peeling off, if it's already making you itch, then by all means, please dispose of your mask already properly. You might think it's still protecting you, but it probably will not be protecting you anymore. And you might want to consider using barriers. So some of us recommend using the surgical mask over the N95 to prevent it soiling. The better option would probably be using a face shield, because that already protects both your eyes as well as preserving soiling or preventing soiling of your respirator mask. Then, of course, additional training should be done with unnecessary contact. Your mask should be treated as infectious when you've already come from patients, and therefore you do not want to touch the front of your mask when you dispose of that. And even when you choose to keep your N95s later on for another use, maybe after the end of your shift or maybe the next shift, where you really have no other options but to reuse it, then make sure when you take it out, you never touch the front of your N95 when you keep it. And if you do inadvertently, then always make sure you wash your hands properly or adequately. So hang the used respirators in a designated storage if you choose to use it again, just to make sure it keeps its its shape. No? Try to avoid putting it or stuffing it into a cabinet or a drawer where you might have other material compressing on it. Keep it clean. And then always make sure it's separated from other users. No? In some hospitals where the resources are limited, the N95 is really encouraged to be reused by some of the ICCs. And again, if that is not, if it's necessary, then as long as all of these conditions are met, then of course label it if you are several people in your ward using your N95s, and make sure you keep it where you know it belongs to you, or amongst the designated areas with your name. So generally, when it comes to PPEs, the WHO recommends or emphasizes the importance of the rational and appropriate use of the PPE, not only the mask, but even your full isolation gowns, whether you use overalls or not. And it's very important also that the behavior of the healthcare worker is established. You always have to be vigilant in handling your PPE, especially in the doffing process of your PPE and the practice of your hand hygiene. It also recommend the WHO recommends also that training, a regular training of the staff should be done. In the ICC should be overseeing this. So in the hospitals where I practice, we've made it a policy that, of course, apart from safety officers that we try to install in the different areas where PPE is the proper donning and doffing is absolutely necessary, but we do have or recommend regular training and observation of the staff, especially when there are shifts of the staff, not only of the nursing staff, but including the midwives, the maintenance, even the housekeeping staff handling that area. The proper donning and doffing of the PPE should be constantly reminded. And then, of course, the other basics would be environmental cleaning, which we will discuss in a while, and then your physical distance and your prevention of symptoms or coming into contact with others when you are already symptomatic. This is a slide just to show you the viability of the SARS-CoV-2. This particular study was performed comparing SARS-CoV-2 and SARS-CoV-1, and some of the more pertinent data that was taken from this was that they tested the viability of the virus through cultures, and they saw that for particular surfaces, these were the viabilities. So for cardboard, it went up to 24 hours, stainless steel, 48 hours, copper, not so high, but plastic, up to 72 hours. Now, I'm mentioning this because I don't know how it is in your hospital, but we've just seen so many hospitals with plastic everywhere, plastic in the triage system, plastic in the triage room, in the ER, everywhere. And it's important if you're going to put up these plastic barriers that they are also subject to the cleaning process that you will do for your disinfection in the patient areas. So they are and should be included in your disinfection of your surfaces. They cannot be dismissed, especially when they are supposed to bar very active movement. Every time you pass through these plastic barriers, you might actually be infecting yourself, not to mention aerosolizing whatever might be in that plastic, because it might be there and it lasts for 72 hours. So how do we sterilize or disinfect patient areas? WHO still recommends the very basic ones, which are alcohol. Ethyl alcohol, 70%, is more powerful than isopropyl and is still the one that is recommended. And it can be used to disinfect small surfaces. It, of course, is highly flammable, so you don't want to use it in very large surfaces, especially near electrical outlets or electrical appliances. But you do want to, this is the disinfectant of choice for disinfecting your small surfaces, especially those that come into contact with your patients. So your BP cuffs, if these are, the vinyl type, or the washable types that are not cloth, or your stethoscopes. No? Bleach, or your household bleach, or your standard bleach, is a strong disinfectant with sodium hypochlorite acting as the active ingredient. And it has always been shown to be effective in killing bacteria, fungi, and viruses, including the influenza virus. One trivia about bleach, for those who are practicing infection control, you know that even in the time of multi-drug resistant organisms, bleach is the one disinfectant that really does not show any resistance, or bacteria that shows that it does not, the bacteria do not become resistant to it. So it is still very effective in these cases, and it is easily, however, it is easily inactivated by organic materials. So where surfaces are dirty, you want to wash these first, with soap and water, or your standard facilities recommendations before you apply and disinfect with your bleach. Now, it's not enough that you disinfect, or you apply the bleach, or you apply the alcohol. The important thing also is to keep the contact time between the disinfectant and the surface. So if you apply alcohol, it's best to let the alcohol dry up on its own. Do not wipe it down. Do not wipe it dry. The same is true with bleach. You want to be able to provide a contact time of 4 surfaces in patients' rooms, about 10 minutes at the minimum to 60 minutes max. And then it's always best to rinse that off, because it can be irritating. In decontaminating environments for COVID-19, we recommend concentration of 1:10 to 1:100 dilution of our bleach with 6.15 sodium hypochlorite. So this is your standard bleach genres that we have. So if you want to just something practical, 1:10 would mean 1 part in 10. So if you were to prepare, let's say, a bottle, you apply 1 ml of bleach to 9 or 10 of your water. Or if you don't have an ml, whatever cup you have, whatever receptacle you have, let's say you have a small teacup of bleach and 9 more of that to create the 1:10, and then 90 for 100 for the 1:99 for the 1:100. So when you clean surfaces, always focus on surfaces where the patients have high contact. So where they are lying down or touching, so the table around the patient's bed, the chair, wherever they are. You want to avoid the possible generation of aerosols, and therefore you want to use damp cleaning rather than dry dusting or sweeping. That's really a no-no in the hospital setting. During wet cleaning, the cleaning solutions can become contaminated, so they should be changed regularly. As a matter of fact, when you do a dilution of your bleach, that dilution should really just last for 24 hours, because it can be affected by heat and different temperatures. So for its viability for about 24 hours. To facilitate daily cleaning, you want to avoid unnecessary supplies. So in your patient's room, all those diapers, all those whatever else goes into your patient's room, set aside a place for all of these things, and that they do not scatter and prevent, that it's easier to clean. Spraying is really not recommended for an occupied or unoccupied room using fogging mechanisms. It's potentially dangerous. There has been no significant benefits seen for these or with these. And then again, if you're going to reuse equipment, follow your hospital's protocols for that one. And as we mentioned, if you have visibly soiled areas, then you want to clean that first. But if these areas or surfaces are not visibly soiled, that you can just wipe these external surfaces of large portable equipment down with your disinfectants. upon removal from your patient's room. So this will include your X-ray machines and maybe your 2D echoes or your ECG machines. Now, this document just showed us a different list of household products, and really what they were able to show was that general precautionary cleaning with detergent and water was adequate for COVID-19 or SARS-CoV-2, and disinfection of contaminated areas as well with alcohol and bleach were okay as long as you provide your appropriate time for contact. And we already mentioned this. Hydrogen peroxide vapors or parasitic vapors and UV lights, these are adjunct measures that might help, but again, they may be costly, no? As compared to just providing your bleach solutions. We mentioned this already. So laundry, fast na. For laundry, again, it's been shown that water and detergent is enough, to clean out those fomites in the laundry, especially those used in the patient's areas. So again, standard, just clean with hot water and detergent, and then soak it first in a chlorine or bleach solution for 30 minutes, and then rinse and dry it off. And for your scrub suits, if you're doing your laundry, then even a concentration of 1:10 to 1:100, as we mentioned, should be enough for your decontamination of your laundry before you rinse it off. Again, so as a wrap up, we want to make sure that the understanding of how it's transmitted, these are droplets that may be aerosolized, but largely these are SARS-CoV is spread by droplets. So you want to protect your conjunctivae and your mucosal linings by wearing the appropriate PPE, using your mask, with your eye protection, with or without a face shield, isolation gowns if necessary, and your gloves. And of course, if you have aerosolation or spills, then your impermeable isolation gowns and disposable gowns might be the better option. And then, of course, thorough cleaning and disinfection is very important, especially high touch point areas. These are the areas we might forget, but these are the ones that are more likely soiled and with a high burden of the virus. So the doorknobs, elevator light buttons, the light switches, handles, counters, surfaces of in the general lobby, and I will include here all those plastic barriers that you have in your emergency rooms and triage areas. So thank you, and we'll answer your questions after Mario's lecture, I think. Thank you.
Okay, thank you very much, Dr. Racolaico, for that very extensive lecture on infection control. And as of now, we collated the questions from our doctors here from the chat room and Q&A. So later, we will forward these questions after the lecture of Dr. Panaligan. So better if you will address your questions to straight to Dr. Panaligan or Dr. Colaico pag in-indicate nyo sa questions nyo later, or if you want to address the questions to the both panelists. No? So just keep posting your questions po dito sa ating Q&A box. Dito po sa baba ng ating screen, no, meron diyang Q&A or sa chat box, and we will collate those questions and then we will relate to them after the lecture. Okay, thank you very much, Dr. Colaico. And now we are going to proceed now. Is Dr. Panaligan here?
Yes.
Hi, sir. Good evening.
Good evening.
Yes. All right. So to discuss about the management, the updates on the PSMID guidelines on the management and treatment of COVID-19 infection. Currently, he is part of the Board of Advisors of the Philippine Hospital Infection Control Society, and he is also our immediate past president of the PSMID. He is also the Vice President of the UERM College of Medicine Alumni Association and the Vice President of the Philippine College of Physicians. His hospital affiliations include UERM, he is an Assistant Professor of Medicine. He is also affiliated at Jose Reyes Memorial Medical Center, which is he's a section head of the infectious diseases. He's also part of St. Luke's Medical Center Global City as the head of the section of infectious diseases, and also in Quezon City as the active consultant. Other organizations, he's a fellow of the American College of Physicians and also the fellow of Infectious Diseases Society of America, or PHICS. May we all welcome Dr. Mario Panaligan.
Yeah. Thank you, Claro. Let me share my slides first. Okay. So, of course, I'll be presenting the updates on the management of COVID-19. I'll try to run through this slide set in 30 minutes, primarily because everything is still evolving. Whatever it is that we know now might not be true in the next few weeks or months, particularly in terms of the diagnosis and the treatment, of course, of COVID-19. So, of course, this data that I had, of course, it's almost 6 million cases worldwide. And certainly, we know that this affects most of the countries. And of course, in Western Pacific region, of course, Philippines still number 4 there. And if you look at the latest, I tried to get today's data. I still could not see it, but still almost 16,000. So I don't know if it's more than 16,000 now. So moving to the management of patients confirmed with respect to COVID-19, certainly the DOH has come out with this case classification. Much important to take note here, of course, those patients with symptoms as well as those patients with exposure. So we classify those without exposure and those without symptoms as non-COVID, and even if they have symptoms but no exposure, it's non-COVID. So if with travel history from a place with local transmission, of course, in the Philippines, most of the communities in Metro Manila, there's sustained local transmission, which was mentioned in the WHO data. They can be classified as suspect and need to be tested. And then probable, inconclusive, or awaiting results, or if the patient clinically compatible, certainly we need to test them and then confirm tested positive, meaning PCR test is positive. And of course, PhilHealth has come out with an ICD-10 classification of COVID-19 so that we can appropriate some or allocate the amount depending on the risk category, whether it's mild, moderate, severe, or critical. Of course, they also came out with help or assistance for the diagnostic testing. So this is the source. If we will look, the latest actually is dated March 31. And this is version 2.1. And tonight we're having a meeting in the board. And I'm hoping that the latest will be out by tomorrow. So I'll be presenting some of the latest evidence in relation to what we have recommended in March 31. And I've actually talked to the current president, Dr. Isa Landry, about what could be out by tomorrow. So this is the website of PSMID, where you can actually download or see some of the important documents related to COVID-19. And you can see that we have a link here for the rapid evidence reviews on COVID-19 management. So this is actually my source for all the evidence. They can look at even the ancillary tests, as well as the ancillary or adjunctive measures that you give, or we usually give for patients suspected of COVID. They're here. And then, of course, we also have the position statement on rapid antibody tests, and of course, the unified COVID-19 algorithms, which are adopted by the Department of Health, including the return to work algorithm that we have released a week ago. So, of course, I need to post this because I also listed some of the recommendations. These have been updated within a month. So we have the latest released yesterday, Clinical Management COVID-19 by the WHO. So all individuals with suspected SARS-CoV-2 respiratory tract infections, or PUI, should undergo testing for COVID-19. And of course, we need to do other tests to check for the parameters to say whether we are dealing to a possible severe infection, or if these patients can be predicted to have a severe infection later on, so that we can be more aggressive in terms of how we're going to manage these patients. So first, clinical presentation. So in this slide, you will see the different studies that compare the different clinical symptoms that are manifested in the patient. So the mean incubation period is around 5 days, and 98% of patients manifest symptoms within 11.5 days of infection. So you can see most are actually presented fever and then cough. And of course, some patients were present with diarrhea. And of course, in one study, many patients presented with fatigue. But other symptoms include the loss of the sense of taste and the loss of the sense of smell, certainly have been reported by some patients. And of course, diarrhea has been reported. Now, before it was around 6%, but certainly it's becoming common. And I got, of course, the first case diagnosing Quezon City manifesting only with diarrhea. So these are the different complications that can be manifested by patients with COVID-19, certain secondary infection, acute kidney injury, um, acute cardiac dysfunction, and ARDS. And of course, the median duration of fever usually is around 12 days, while cough can extend up to 19 days. Now, comparing survivors and non-survivors, practically all signs and symptoms, fever, cough, and dyspnea are manifested. But you can see here that the complications are much more frequently seen among those who did not survive, including the AKI, acute cardiac injury, and of course, the secondary infections. So most of these patients would usually present with dyspnea, shortness of breath, and they later on will develop other complications, including acute kidney injury, and of course, even liver dysfunction. And these patients are also found to have hypercoagulability, and many patients with severe illness will also present with cytokine storm. And that's the reason why there are lots of interventions are being tried, but most or almost all have not been proven to be truly effective based on the evidence. So these are the risk factors for outcome. Of course, even in the early reports, old age as well as diabetes, coronary heart disease are common among those patients with severe illness. And of course, on laboratories, they are found to have lymphopenia, elevated ALT and LDH, and even elevated TROP-I, elevated ferritin, procal, and of course, IL-6 can be seen among patients with severe disease, of course, higher SOFA score and high D-dimer, which can predict, of course, who among these patients can later on progress to worse outcomes. Now, moving to the tests for COVID-19, certainly at this time, the real-time reverse transcription polymerase chain reaction assay is the preferred test, primarily because this can detect active or acute COVID-19 infection. And certainly you can or you should actually submit multiple swabs. So if we include, for example, nasal swab and pharyngeal swab, combining these two is around 95% yield for detection. And this is actually based on one good study that looked at the different specimens. Certainly when you talk about bronchoalveolar buds, that's the highest yield. And most of the time, of course, we're talking about those patients with illness who have been intubated or who have been having non-resolving pneumonia, and therefore bronchoscopy and bronchoalveolar buds were submitted. And of course, brush biopsy can also yield good results, but definitely still bronchoalveolar buds followed by sputum. And of course, feces can actually produce positive results, but certainly up to now, the transmission through the feces is still undocumented or not truly well documented. And if we're handling feces, of course, we just have to observe proper hand hygiene and of course disposing these materials immediately. So this is just a table that will look at will show, of course, the different laboratories in the Philippines that can do RT-PCR. So there's a lot. Unfortunately, there's still delays, and that's the reason why they said the 539 cases that were reported yesterday was the backlog, and this is primarily due to aggressive testing of those who have not yet been reported previously. Now, moving to serology-based tests for COVID-19, and there are three forms. There are three types: the rapid diagnostic test, the enzyme-linked immunoabsorbent assay, or ELISA, or the neutralization assay, or the PRNT. Certainly, the problem with rapid diagnostic tests, which is widely available in the Philippines, is that these are qualitative tests, and therefore, it will just report to you whether it's reactive or non-reactive, and will not tell you whether you are protected. Primarily, we don't know the quantitative levels. No? And of course, the biggest problem in serology tests, particularly with the antibodies, is that this will not turn positive during the first few days of illness. And now for enzyme-linked immunoabsorbent assay, this can somehow give you a quantitative levels of the antibodies, and somehow if this is truly validated, like what is now being pursued here in the Philippines, because there will be a study on the quantitative test results, this can somehow tell us whether the patient has IgG, and combining it with IgA, then that can then tell us whether the patient already protected, because this can tell us whether the patient indeed had protection previously and now has developed antibodies. Now, the neutralization assay is the best actually, primarily because this can tell you whether there are active antibodies in the serum, and certainly that can indicate protective immunity. And unfortunately, this is not available and usually done in special laboratories. Now, this is a good figure that can tell you how or when the time should actually we should perform an antibody test. So if you look at this one, the IgM, for it to become positive, usually it will take around 5 to 7 days. Then it peaks usually on the 14th day. Okay, and then it will go down eventually the next 2 to 3 weeks. Now, for the IgG, usually it starts to go up on day 14 or day 10, then it peaks in day 21, and then it can persist even for 4 to 5 months. And that's the reason why when we talk about IgG, if we are going to do it, make sure that we request for a reliable antibody test that is available. Unfortunately, up to now, there's still no qualitative antibody test that's validated useful for us to tell whether the patient is truly protected or not. Now, moving to drug therapy for COVID-19. Now, you see that I placed here the consent form for off-label use of the drugs, primarily because all the drugs that we know that have been reported abroad that can be effective are not yet proven. And therefore, most of these drugs are used for off-label indications, and therefore we need to inform the patient before even prescribing this that we are just using this because of the possibility or theoretical reason that this can work for our patients. And therefore, it's a must that we assign informed consent before giving it. And then second, we need to explain, of course, the currently available evidence, which is still limited, and of course, the potential adverse drug reactions, which are plenty, particularly with what we have seen in hydroxychloroquine and chloroquine. Now, Solidarity Clinical Trial is a WHO-initiated clinical trial, and we're fortunate that because of Dr. Marisa Alendria, we are now part of the global trial that look at COVID-19 treatments. And certainly this is ongoing up to now, and there are more than 20 hospitals in the Philippines that are involved, and there are more than 150 patients enrolled in the Philippines. But globally, I think it's almost 2,000 now. Now, I have to place this slide primarily because of what is contained in the WHO May 27 interim guidelines with the use of antivirals, immunomodulators, and other adjunctive therapies for COVID-19. And they said, we recommend that the following drugs should not be administered as a treatment or prophylaxis for COVID-19 outside of the context of clinical trials. So, pag hindi pa tapos ang clinical trial, alam natin, hindi pa siya effective, and therefore, we need to be very careful when our patients are asking. And certainly, we need to explain to them, hindi pa sila proven, hindi pa natin alam kung gagaling ka, at saka posibleng maraming side effects na kuha. So, at saka marami pa naman dito, hindi pa rin approved sa ating local FDA. Now, of course, chloroquine, hydroxychloroquine, I mentioned that, because of Trump before, because of the small French study that somehow reported the usefulness of hydroxychloroquine with azithromycin. Sabi niya, 100% viral clearance compared with hydroxychloroquine alone. But that is actually 6 patients who received both hydroxychloroquine and azithromycin. Of course, antivirals, including lopinavir, ritonavir, which is anti-HIV drug. Of course, remdesivir, remdesivir, and favipiravir. Immunomodulators like tocilizumab, interferon beta alpha, and even plasma therapy, which is becoming popular primarily because of the advertisements, and of course there are some who have recovered from COVID, even senators donating plasma for use. But again, be careful, and of course we must know that the data or evidence is still limited. And in fact, if you review the rapid reviews, you will see that most, almost all, do not show any sufficient evidence that would warrant its use because there's still no data. Now, this good figure that I got from JAMA, this was actually regarding the life cycle and the potential drug targets. And you can see that based on the life cycle of SARS-CoV-2, certainly lots of drugs can actually play a role in, of course, inhibiting fusion and entry, and of course, the replication, and of course, upon the release with the new virus, when it, of course, is engulfed by the macrophages releasing more cytokines, including IL-6, certainly an immunomodulator can be given. So this is the reason why some of these drugs may work. However, up to now, we still don't have any sufficient evidence, except for one that I'll be showing you later, but still inadequate in terms of saying whether this drug combination is actually effective. So they are classified as purpose agents or investigational drugs. No? So let me present the algorithm that we released in the last guidelines, or the last updated guidelines. And up to now, we still recommend that for patients presenting with fever, with respiratory symptoms like cough or shortness of breath, and of course, we need to know the other signs and symptoms as well as a comorbid illness, or whether the patient is an elderly or senior. And then, of course, that patient will consult the primary care facility. And then we still need to investigate, evaluate if the patient is not having desaturation or not tachypnic or not having any alteration in the mental state. And therefore, if these are absent, they may still be handled by the primary care facility and can be sent home, provided that an advice on proper infection control, isolation, should be observed by the patient. But do not forget, of course, knowing whether there was indeed exposure history. Now, if the signs and symptoms of worsening is present, or if there is desaturation, alteration of mental status, or if the patient is elderly and there's comorbid illnesses, then you refer this patient to a designated COVID-19 facility. And here, they may need to be admitted, of course, and they should be monitored, given supportive measures or the standard of care. But certainly, it's a different story if they saw that this patient is already deteriorating, or there are signs of progressing or progressive disease, then they need to get admitted in the ICU. So this is the management algorithm for probable or confirmed COVID-19 pneumonia. Now, this is not yet including the remdesivir. Before, of course, the trial, before the Solidarity trial, because remdesivir is part of the Solidarity trial. And you can see that patients with COVID pneumonia, and then if there's no sign of desaturation, the patient is also young or without comorbid, then they can be classified as mild or low risk. Then again, they can be sent home, but make sure that they are isolated. Now we have quarantine facilities, and therefore they can be sent there so that they can be quarantined adequately. Now, if the patient has comorbid, or the patient is at least 6 years old, then you can classify them as moderate, then admit, then you can give either chloroquine, hydroxychloroquine if they are eligible. Now, if they're not eligible, then you give the lopinavir, ritonavir. So again, this is usually moderate cases. But of course, if there are signs of severe infection, again, there is alteration of mental state, or there's desaturation, impending respiratory failure, then admit to the ICU, then you can give chloroquine or hydroxychloroquine if it's eligible. But if not, then lopinavir, ritonavir. And then if there's worsening of the manifestations, then you classify them as critical. And then certainly you can consider giving an immunomodulating agent, like tocilizumab, because we can now say that the patient may be manifesting with a cytokine storm. Now, again, when I said eligibility due to chloroquine, hydroxychloroquine, you just have to take note, of course, of possible cardiac dysfunction or heart failure, because they can actually develop prolongation of QT. And certainly, if they have the G6PD deficiency or their elevation of the transaminases, certainly these are contraindications for the use of chloroquine or hydroxychloroquine. Now, these two, CQ and HCQ, are anti-malarial and anti-inflammatory. Again, these are the problems with these drugs: QT prolongation, retinal toxicity, hypoglycemia, CNS, neuropsychiatric manifestations. And you can see that last week, of course, we received, dated May 24, Sunday, we received, of course, a notice from the WHO regarding, of course, the release of review of the different trials and non-randomized studies regarding the use of HCQ for the treatment of COVID-19 among hospitalized patients. And you can see in that particular review, they have mentioned, of course, the frequency of cardiac side effects among those who actually receive hydroxychloroquine and chloroquine. And also that there's really no benefit in terms of this particular agent when these are given to patients suspected or those with probable COVID-19. Now, if you look at this Cochrane review, the latest one on the safety and efficacy of hydroxychloroquine and chloroquine for treatment of COVID-19, this certainly will tell us there's still no good evidence, but certainly it has shown that there's still no difference in all-cause mortality, and even with the short time to mechanical ventilation still not proven. And of course, the likelihood of QT prolongation would be present, would be manifested by the patients receiving hydroxychloroquine. Now, lopinavir, ritonavir, primarily used for HIV. This has been used previously for SARS, with documented faster reduction of viral load, and eventually recommended for MERS-CoV. Now, just remember the side effects. Patients will present nausea and vomiting, diarrhea, and similar to hydroxychloroquine and chloroquine, they may cause QT prolongation. Now, there are two open-label randomized controlled trials that showed no significant reduction in mortality and acceleration of clinical improvement. Now, currently, with 16 ongoing clinical trials, and we will see whether this particular agent can be useful. And lopinavir, ritonavir is also part of the Solidarity trial. Now, moving to this algorithm, now this time remdesivir is available, but I have to repeat, remdesivir is part of the Solidarity trial. So here in the Philippines, we can use it for as long as they are included in the trial. Of course, there are already some companies that have applied for emergency use of this drug, and hopefully they can be approved, or if they have approved, we can hopefully use them for compassionate use. Now, when we talk about remdesivir, certainly this is an option. For example, if a patient already has moderate COVID pneumonia, and of course, if there's any of the following, if there's no evidence of multi-organ failure, and the patient is not pressure requiring, and the creatinine clearance is, of course, normal or more than 30 cc per minute, and of course, the liver function tests are normal, then we can consider remdesivir IV 200 milligrams one time and 100 milligrams IV daily for the next 10 days. And of course, for the rest, we can still follow the same algorithm for both lopinavir, ritonavir, although now hydroxychloroquine has been suspended in the Solidarity trial. Therefore, we need to exercise caution if we even think of giving hydroxychloroquine or chloroquine. Now, this has been published or released on March 31, and at that time, we are already vocal in saying that the use of chloroquine and hydroxychloroquine should not be considered as a prophylactic agent to prevent COVID-19. Now, with regards to tocilizumab, an anti-IL-6 immunomodulator, certainly it's actually used for rheumatologic disorders, but we can consider giving this particularly among patients who are not responding to the initial drugs or to the supportive measures that we are administering to our patients. So clinical criteria include those with severe manifestation, tachypnea, even desaturation, PaFiO2 less than 300, And of course, those patients requiring mechanical ventilator or those presenting with shock. And of course, diagnostic criteria include fever, hepatosplenomegaly, mycytopenia, hypertriglyceridemia, high fibrinogen levels, and high ferritin levels. Okay, so we can give this, but just remember the price is actually around 50,000 a vial. And just remember, of course, the absolute contraindication, elevated transaminases, thrombocytopenia, neutropenia, and hypersensitive drug, and of course, active tuberculosis. Because even if we want to give this, we still need to screen them for latent TB as well as possible hepatitis B infection. Now, remdesivir, this is an antiviral drug that inhibits RNA-dependent polymerase. Now, if you look at the latest randomized controlled trials that were done, again, on patients with severe COVID-19, these trials have shown faster clinical improvement by 3 days, increased recovery rate, and there's a trend, a trend for lower 14-day mortality rate. And that's the reason why it has become popular. Many of our colleagues are asking if they can use it for compassionate use, even if they're not included in the trial. However, we're still waiting for the FDA approval, and certainly this can be a good drug, but we need to observe and wait for the other RTs and of course the results of the Solidarity trial. Now, favipiravir, popularly known as Avigan. Ito naging popular din kasi meron daw ibibigay sa Pilipinas, donate ng Japan, and there could be a trial which I will be involved with, involving different hospitals. This is an antiviral drug previously approved for influenza in Japan in 2014. It inhibits RNA-dependent RNA polymerase and subsequently viral replication. So one randomized study versus Arbitol showed no difference in clinical recovery in patients with severe COVID-19. Now, a non-randomized open-label trial versus lopinavir-ritonavir, there's a significant reduction in viral clearance with higher CT scan improvement in patients with non-severe COVID-19, but they have noticed some flaws in terms of the methodology of this particular trial. Now, for the side effects, diarrhea, liver and kidney injury, elevated uric acid, psychiatric manifestations, even QT prolongation. Of course, we need to be careful in terms of pregnant individuals or children. Now, there are 23 ongoing clinical trials for this, and of course, we have to wait for the results. For us to be convinced whether this particular drug is effective. Now, these are, of course, our goals when we handle patients with COVID to prevent complications. Certainly, we need to reduce, of course, the need for mechanical ventilation, reduce the incidence of VAP, reduce incidence of venous thromboembolism, primarily because of hypercoagulability, reduce incidence of catheter-related infection, reduce incidence of pressure ulcers, incidence of stress ulcers and GI bleeding, and of course, incidence of ICU-related weakness. Now, when do we do repeat testing for COVID-19? So 14 days after first positive test or a fever for 72 hours, then we can submit a nasopharyngeal or oropharyngeal swab or even a lower respiratory tract specimen. Now, if it's still positive, then you can recollect these swabs and after 14 days. But again, you need to advise quarantine. Now, if no test kits are available, you can send patient home, once asymptomatic and clinical stable. Ang problema lang, syempre, minsan ayaw na umuwi, gusto lang nasa hospital. And of course, that's the reason why sana meron tayong maganda tayong quarantine facilities that can accommodate these patients who have mild disease. Of course, we need to advise them properly na dapat walang lalabas. Hindi kasi sa atin sa mga Pilipino, uso, labas tayo ng labas. Certainly, we need to be strict, and therefore the quarantine, the ECQ that has been implemented actually worked a little because there's definitely a decrease. However, maintaining it's quite difficult, and the GCQ that will be implemented in June 1, I hope that there will be no more, or I hope that the surge will not immediately. And of course, we need to repeat the tests, the test once PCR test is available. Now, repeat testing after initial negative COVID-19 tests. Of course, if there's a high probability because of the manifestations of your patient, the possible COVID, then you need to repeat it, if there is an initial negative test result. And you can definitely do it immediately if there's clinical deterioration, particularly in the presence of established disease etiology and with adequate treatment. Halimbawa, tinitreat ng bacterial infection, tapos hindi pa rin nag-improve, then repeat, lalo na kung negative yung COVID-19. If there's no other etiology for the patient's signs and symptoms have been identified despite workup, and of course, if the clinical specimens initially sent was deemed to be unsatisfactory or insufficient. So what are the criteria for discharge of COVID-19 probable or suspect case? So after initial COVID-19 test is negative and any one of the following is met. No? There is clinical improvement. The patient has become asymptomatic. No other indication for admission. And of course, if there's another diagnosis and the probability COVID-19 has been ruled out. Now, for patients with confirmed COVID-19, certainly we have to evaluate them if they're clinically recovered. Certainly, we can discharge them from the hospital after a single negative test, provided that this test will be repeated within the next 2 weeks to document really twice negative PCR. Because it's quite difficult to rely on just one negative test because this could be a false negative result. And certainly, if this is not feasible, discharge upon discretion, and certainly you need to advise them to quarantine themselves in the next 14 days. Make sure that this test is repeated. Now, alternatively, IgG can be done as an adjunctive tool to clear quarantine patients, particularly among patients who are asymptomatic. And when you talk about IgG positive, then you can release them from quarantine. But warning lang, kailangan reliable yung test. Kasi yung rapid antibody test natin ngayon, wala pang nababalidate. It's ideal that we can do quantitative test. I heard Dr. Ray Law of the PSP saying that it is available. However, they just have to be given the go signal so they do the test. But certainly this is not widely available. And certainly if this can be pushed by the Congress, which I mentioned that to Congressman Garin earlier, that's why I was late. I do hope that we can have a more reliable tool to know whether we are fully protected or not. And certainly antibody tests can be used for the zero prevalence of disease, particularly if we really have a controlled pandemic, and therefore we just need to who among our fellow men are already immune to the disease. And of course, if there's negative IgG, we need to repeat the RT-PCR. Now, these are the indications for resolution of symptoms: normal temperature for more than 3 days, significant improvement of respiratory symptoms, significant improvement of the chest radiograph. So again, this is highlighted in the DOH guidance and also PSMID guidelines. For RDT kits, they should be FDA approved, but of course, it's much more ideal to use a validated test kasi nga wala pa hanggang ngayon. They cannot be used as a standalone for definitive diagnosis. And again, look at the time when you should do this, particularly among those individuals who develop symptoms. And again, a positive IgM needs to be confirmed with RT-PCR, and only MDs can prescribe and interpret the use of this antibody test. So to repeat, a negative IgM does not rule out COVID-19 primarily during the first week of illness, particularly among those symptomatic individuals. They should remain isolated and should be swabbed using RT-PCR for confirmation. IgG without PCR, presumptive past COVID-19. However, this should still be validated by a quantitative test or even a viral culture or, if possible, a PCR. An IgG is an adjunctive test to clear quarantine asymptomatic patients 14 days post-discharge. A positive IgG, they can be released asymptomatic individuals. And I will just show you the latest recommendations from the WHO in their guidelines released November 27. So for the discharged patient, close follow-up is necessary. Again, home quarantine for 2 weeks post-discharge. You can discharge mild cases, again, quarantine for the next 14 days. Now, for asymptomatic COVID-19 positive contacts of confirmed cases, you need to advise them home quarantine monitoring for 14 days. Kung wala namang symptoms, then okay lang. But of course, if develop symptoms, advise immediate consult. And of course, depending on the ID assessment or the assessment of the doctor, then we can actually advise them doing a swab, depending of course on the clinical status of the patient. Now, advanced directive, certainly in handling complicated or serious COVID patients, it's not really easy. Number one, primarily because they can deteriorate fast. And certainly advanced directives have to be mentioned or DNR for patients with severe COVID-19 infection. So may withhold CPR on critically ill patients with no reasonable chance of recovery. And certainly we can see this in patients ARDS, secondary to high-risk pneumonia, not responding to treatment, those patients with refractory septic shock and multi-organ failure. Now, we can follow the advanced directive of a free and informed decision of a DNR made by a competent patient or an appropriate proxy. Now, we make decisions based on futility, the best interest of patients, and of course, scarcity of resources, and certainly, of course, the safety of the healthcare providers. And we exert efforts to provide spiritual support and counseling for patients and families. Immunization have to include this primarily because this is still quite valuable, particularly among those other infections that can be prevented by vaccines, including flu, and of course, pneumococcal vaccines among those who are at risk, the vulnerable, particularly those with comorbid illnesses. And therefore, we need to consider this, particularly those individuals who will need this. And of course, we can suspend temporarily the mass vaccination campaign, but we still need to advise continuation. We can give boosting up immunizations, primarily because we just have to make sure that these patients are adequately protected. For the WHO guidelines, the guidance is updated with these new sections: COVID-19 care pathway, treatment of acute and chronic infections, management of neurological and mental manifestations, non-communicable diseases, rehabilitation, palliative care, ethical principles, and reporting of death. But let me just mention the highlights of these guidelines released the other day or yesterday here in the Philippines. So transmission-based precautions. You can discontinue transmission-based precautions, including isolation and release from the COVID-19 care pathway for symptomatic patients 10 days after symptom onset. Plus an additional 3 days without symptoms. Ibig sabihin, pag wala na silang symptoms, 3 days, okay na. This is based, of course, on the observation that viral shedding of up to 9 days for mild patients up to approximately 3 weeks in hospitalized patients. So, ibig sabihin, pag walang symptoms, the likelihood of release or shedding of the virus is almost nil. And despite, of course, the knowledge that patient can remain consistently polymerase chain reaction positive for many weeks, or even if we see this, of course, that kung negative sila, nagiging positive ulit, similar to that senator, we can actually still think that this could just be fragments of the virus. They have already dead, and therefore these are no longer infectious virus. So this new recommendation comes from WHO. For the treatment of acute co-infections, for suspected or confirmed mild COVID-19 patients, the use of antibiotics for therapy or prophylaxis should not be used. Now, for those with moderate COVID-19 cases, antibiotics should not be prescribed as well unless there is a clinical suspicion of a bacterial infection. Siyempre, sa umpisa, when we see patients, we also consider coexisting bacterial infection. That's the reason why we also adopted, of course, the CAP guidelines that we just updated this January. And we follow, of course, the moderate risk as well as the high-risk category. And certainly, once we have ruled out coexisting bacterial infection, for example, if your hospital is a PMRA, a pneumonia panel, and we have ruled out coexisting bacterial infections, certainly we can discontinue the antibacterial drugs. Now, pharmacologic prophylaxis, a solo molecular heparin like enoxaparin can or should be used to prevent venous thromboembolism. This is quite common. In fact, it is recommended by experts that we can extend enoxaparin for 4 to 6 weeks post-discharge, primarily because of the persistence of the high probability that can make them develop venous thrombosis and later on pulmonary thromboembolism. Now, for those with contraindication, you can use mechanical prophylaxis like pneumatic compression devices. For the key interventions, the WHO recommends that the listed drugs, including antivirals, immunomodulators, and other adjunctive therapy, should not be administered as treatment or prophylaxis for COVID-19 outside the context of clinical trials, just like what I said earlier. So just for emphasis, we should not think of giving those drugs which are not yet proven, unless, of course, they are necessary and part of the clinical trial. Now, WHO recommends against the routine use of systemic steroids for the treatment of viral pneumonia. Now, right now, we still need to stay home, no? Until, of course, Sunday, by January 1, DCQ. But we still need to be very careful. I advise that we still need to observe social distancing. This has been a quite popular picture by our colleague, no, our alumnus, Dr. Radi Menes. Stay at home as we stay here for you. No? And certainly, when we talk about the ACQ and social distancing, which is still very important when the GCQ is implemented. No? Of course, the main goal is still to flatten the curve, and of course, this measure will only buy time, certainly, and certainly this can protect us from acquiring the virus. But certainly, if we do not continue practicing this, there's still this risk of danger of getting it. So just remember the three considerations for when it's safe to come out again, cases no longer spreading widely, stronger healthcare system, and of course, the capacity of public health, no, to trace contacts immediately so that we will know who among our colleagues, our fellow men are infected and therefore can be isolated, quarantined properly. Three considerations for how to safely lift physical distancing restrictions or loosening the faucet. Medically vulnerable, continue to shelter. Sila yung madaling magkasakit, sila rin pwedeng magka-problema, magka-komplikasyon. Prioritize societal benefit, of course. Opening of classes may be considered, but syempre, dapat wag muna. Of course, nakaplano na sa August 24, no? But of course, we need still to look at the possibility of online learning, no? And of course, we need still to continue sanitation, disinfection of the environment, particularly the facilities. And then, of course, we need to prepare to tighten the faucet if cases spike. Of course, this is the solution. Hopefully, ang hope ko sana at the end of the year, but it was announced that it can be available earliest daw January, February next year. But again, may nag-apply na rito from China, dalawa. Hopefully, makasama tayo sa trial. This is a phase 3 trial, and hopefully, these are proven to be effective so that they can be used immediately. So, for the new normal with COVID-19, the next steps we must take, we may adopt new ways of meeting with colleagues and with friends. That will require more forethought. And still, we need to wash our hands more frequently, cover our cups more carefully. Moving forward, we recommend adjustment to public health and social measures in the context of COVID-19. With the following requirements. COVID-19 transmission is controlled through two complementary approaches, breaking the chain of transmission by detecting, isolating, testing, treating cases, and quarantine contacts and monitoring for disease circulation. The measures are established in the workplaces, capacity to manage the risk of exporting and importing cases from communities with high risk of transmission. And of course, the community should be fully engaged. Of course, I'm not saying that it should be as strict as before, but certainly we need, of course, to emphasize the importance of physical distancing and, of course, application of infection control measures. So avoid complacency in infection control, as emphasized earlier by Dr. Kulaiko, and of course, watch out for the latest update. This will be the guidelines on the management of COVID-19 very soon. I hope that it will be out tomorrow. Right now, there's an ongoing PSMID board meeting discussing this. Thank you very much.
Okay, thank you very much, Dr. Panaligan, for that very extensive and updated. I think parang itong mga WHO recommendations, parang they just came at ito lang, latest lang, especially when it comes to disposition of patients who are asymptomatic or those who are being managed as mild patients. So, and at the same time, we also get updates from the recommendations about the use of hydroxychloroquine, mga ganyan. So, these recommendations are very dynamic and keeps on evolving. So, yes, gaya ng sabi ni Sir, we just keep ourselves updated sa mga susunod pang mga recommendations from these organizations and societies. Okay, wait lang. Mag-video daw ako. Okay, sige. Alright. Okay, so medyo multitasking ako on my end. Dr. Kay Panganiban is also helping me collating the questions, and at the same time we're trying to answer your questions in as much as we can, ano? So Dr. Panaligan and Dr. Colayco, so we have collated some questions here na nakuha namin from the chat box and from YouTube and Facebook. Yan. Sige. Eto, so may mga advanced questions din tayong nakuha from email prior to when they registered. So we will also include those dito sa questions natin. So, okay, to Dr. Colayco. Okay, so someone asked here that, are there any recommendations regarding the use of air purifiers or HEPA filters, as well as the use of UV light or lamps? I think this is with regards to sa reopening ng clinics, mga ganyan, ano, ng clinics or offices or even at home, no? Any recommendations about the use of these devices? Opo. Doctora, I think you are on mute po. Yan po.
Okay,
Thank you
yeah.
po.
With regard to the use of HEPA filters, again, the HEPA filters do not influence the air exchanges, no?
Mhm.
But they can still give better quality of the air that circulates within the room. It is not a recommendation, a primary recommendation for actually the best option for using in cases where you might experience aerosolization. Again, air exchanges are still the more adequate management procedure for that. You have to, of course, consult with your engineers with regard to room size, window sizes, exhaust fan sizes for that. But the HEPA filters can be a substitute in the event that you cannot, in fact, open your windows, no, and you might not yet have your exhaust fans, although that would be ideal. It may help clear out the particles. Again, the HEPA filters are only going to clear out what's in the air, no? If your COVID-19 is not being aerosolized, no, it's a droplet, then it doesn't really stay suspended for a very long time. So it's not the best still for air exchanges. UV lights. We've always known that UV light has been effective or is effective. Someone asked about the nanometers. I'm afraid I don't know the answer to that. I'll have to get back to that. What is the minimum that will not cause harm to skin and eyes? I think that's the question. I don't have the answer to that. But the thing about UV light is its effect when you use it on surfaces is that it will only disinfect the parts that come into direct contact with it. So if you're looking at the UV light to disinfect your whole clinic, then that's going to be a problem because it will not reach under your desks or under your chairs unless you strategically put it there every 30 minutes and that's all you did for the whole hour is just move around. Then it doesn't really help much as compared to just doing your surface disinfection with your household bleach.
Yeah, I think the comment niya sa UV sterilization, I think it can be used as an adjunct, no? But it cannot be used as a standalone disinfection kasi we have to take into consideration kasi yung mga fomites, ganyan, and yung mga soiled mga surfaces, so it has still to be disinfected with the usual surface disinfection, and you can use UV sterilization as an adjunct for that, no? Yes. Okay. Tapos, ayan. In our clinic to, Dr. Panaligan and Dr. Colayco can answer. In our clinic, all of us are very concerned about this. Do we need to, what is parang the minimum PPE? Or parang na dapat should we wear a complete PPE, or is surgical face mask enough for us in the resumption of our clinics?
I think it will, as I answered earlier, I think it will depend really on what the nature of our practice is. If our practice involves, let's say, if we're an ENT or a surgeon, or our practice involves, or even a pulmonary specialist, involves some aerosolizing mechanisms or procedures, then you might want to step up and really use your N95 protection, no, on instead of just a surgical mask, with your face protection again, no, with or without the goggles. Is an isolation gown necessary? Um, it depends again on the nature of your practice. So if you expect aerosolizing procedures, it might be best to protect yourself also from contamination. But otherwise, if you would just be ensuring that you get to interview your patient, do a brief or a quick physical but adequate examination, then and you don't expect much body contact, then just the mask, which is a surgical mask, should be enough. I would recommend a face shield with or without the goggles, no? Just in case there's a sudden SMID and a cough, that happens there without a mask. And you may or may not use gloves, no, but you can just wash your hands before and after touching the surfaces where the patient was in examining your patient. Yeah. I don't know
Yeah.
about Mario.
Mm. Okay. Kasi if you will review the risk stratification of the CDC, no, if the patient wears mask and if the healthcare worker also wears face mask, actually that will put you on low risk na. So very important din na hindi lang ikaw ang merong suot, you also encourage them that the patients should also wear face mask kasi by that alone can already pose you at low risk na. So parang ganun. Sige. And Dr. do you have experience daw po on elastomeric respirators? Like for example, yung mga 3M na mga malalaking ganon. If they can be safely reused or process on how to disinfect it after using it? Any experience about that po?
Well, I certainly don't use it. It's kind of heavy, but we usually recommend to cleanse those filters or change them based on the manufacturer's recommendation. No? So there is actually, depending on the kind of filter, there are those that you can extendedly use for several days, no? Depending on how much time you have in contact with your patient. If it's straight hours, 8 hours, or if you're intermittently using it, then it will have a longer stay than maybe if you use it continuously. No? So as far as the maintenance of those filters, we really recommend the manufacturer's recommendation for those. So the pancake type, which is the N95, no, and then the cartridge type where you can change the filter. I personally don't use it because it's heavy. It's heavy to be making rounds on it. The N95 is enough.
Okay. Okay, Dr. Panaligan, yan, may tanong. Akala mo si Doktor lang may tanong. May tanong din sila sa iyo. Okay, so we explained about parang criteria for suspects, no? So we have the symptoms and then they just want to clarify what counts as exposure at present. So can we clarify further what constitutes parang an exposure, a significant exposure? Is it pertaining to areas or direct contact pa with an infected individual?
Yeah, thank you for that question. Siyempre, when you talk about exposure, significant exposure means you got exposed to a confirmed COVID-19 patient. That's number one. Now, if you're in the household, for example, one of your household member got infected, and because that patient has been confirmed, and therefore all the household members are exposed, regardless of how intimate, kasi magkakasama sila sa bahay. Therefore, nandun na exposure. Now, binanggit ko kanina yung community, certainly, alam natin may mga hotspot barangays. And when you talk about hotspot barangays, magkakatabi kasi yan. For example, yung number 1 dito, malapit sa amin, sa Addition Hills. Magkakatabi talaga ang bahay dyan. So, when you talk about that community, you can consider that as exposure if you're living in that community. I'm happy that they're doing this contact tracing there. Unfortunately, I don't know how they're doing it. Kasi when we talk about expanded or definitive testing, yung hindi naman daw mass testing ang gagawin, talagang tama naman na hindi. Kaya when we talk about expanded or definitive or I forgot the term, but in definitive testing, yun yung similar to contact tracing. So kung sino yung katabi niya na bahay, dapat lahat yun, yung katabi, surrounding the area. So talagang yun at risk na magkaroon.
Yeah.
So yun yung exposure. it's not easy before, no? Kasi hindi pa natin alam noon kung saan talaga madami. But now, identified mo yung mga barangays And when I was asked before, meron bang community transmission? I would say yes, meron talaga in some areas. And in fact, in the WHO, tayo sa Western Pacific region, tayo lang ang nakasulat doon na community transmission. The rest, only clustered cases. So, yun. Kasi exposed to somebody who is sick, and of course, even if it's just not confirmed, it's a probable, meaning it's actually being worked out for COVID, then it's a significant exposure already.
So doon po papasok yung if you are within the 2-meter exposure, or parang if the exposure was more than 5 minutes or 3 minutes, parang ganyan, and merong direct body contact or pati respiratory droplets were exposed. So yun po yung mga significant. And of course, sabi ni Dr. Panaligan, with the sustained community transmission, the risk of having parang contact with this symptomatic patients are very high, no? Now we are talking about symptomatic patients, but there are a lot of questions, Dr. Colecon, Dr. Panaligan, about asymptomatic patients, no? So we discussed about contact tracing in patients who are exposed, no? But how about asymptomatic patients, no? Do we include them in contact tracing, or do we advise them to be tested or swabbed then in asymptomatic patients?
So ako muna?
Sige. Dr. Panaligan, sige, you can go ahead po.
Sige. Of course, asymptomatic individuals can be tested. Of course, much more ideal to do the PCR testing, particularly if there is a confirmed COVID-19 patient in that particular area. Or, ulitin ko for example nga sa isang barangay, nandun siya. When I was talking about significant exposure, kasi you cannot really say if their exposure from an individual is less than 5 minutes. For example, kung magkakasama talaga sila, lagi sila nakita-kita. So, hindi na natin malalaman kung less than 5 minutes yan, or more than 5 minutes, or even longer than 15 minutes, kasi mahilig sila magkakasama. So, even if they are symptomatic, if that index case is confirmed to have COVID-19, therefore, they should be tested. And that's primarily the reason why yung targeted testing, now I remember the term, targeted testing can be done, but I prefer, or because the preferred testing is PCR, then definitely that should be done. Not the rapid antibody test that is being done nationwide. Yeah.
Okay. So far, ayan. So papasok tayo ngayon dun sa issue about the screening tests, no? So comments about rapid kasi parang there are a lot of private sectors right now who have been urging their workers to undergo mass testing with rapid tests. Any thoughts on this? And is it a dagdag gastos lang ba? Is it an additional expense lang that is unnecessary? What do you think about these doctors?
Una kong sagot, gastos siya. Dagdag na gastos. Primarily because I've explained earlier, no? Although hindi ko mahabang in-explain yung figure, I remember I mentioned that the first 5 days, usually negative yan, yung IgM test, and therefore if the patient is already symptomatic, no, may ubo, may sipon, tapos tinest siya, no, ng antibody test, malamang sa hindi negative yan, and that can be a false negative result. And therefore, remembering, if you're gonna clear that patient to go back to work, hindi natin alam kung may dala siyang virus, and therefore that can ease up the transmission, no, to other workers na magtatrabaho sa kanya. Of course, when I said na yung antibody talaga hindi maganda, no, primarily because hindi siya validated. No?
Yes.
Kasi there could be cross reactions as well, no, with other coronavirus infections. No? Tandaan natin, coronavirus is the most frequent reason why we develop common colds. So, yan ang talagang pinakadahilan kung bakit tayo nagkakaubot-sipon palagi. And therefore, this can become positive if you develop just recently, no, common colds. So, meron kang sakit pala, meron kang coronavirus, bigla mangingilag na yung mga tao, ika-quarantine siya. When in fact, hindi naman pwede. Dahil wala naman talaga siyang coronavirus. So that can be a mistaken, it can become a mistaken identity. Ibig sabihin, magkakamaling tao, mangingilag yung mga tao, and that's a stigma, of course. So that's basically the problem with the rapid antibody test. Walang problema sana if these are validated. No? I mentioned, of course, Dr. Raylo earlier, that he mentioned about the quantitative ELISA or the chemiluminescence test, and that will give us a quantitative results. In fact, we mentioned about the IgA. I know about the IgA when combined with IgG. That can definitely help tell us that the patient is already protected. But then again, we just need to know when it should be done. Kung gusto talaga nilang pagawa, and it should not be done for they term as mass testing or even targeted testing, primarily because of the high likelihood of false negative and high likelihood of false positive results.
Okay. How about doctor? How about the possibility of transmission in asymptomatic patients? Parang a lot of questions are now coming in. Is this still possible at this time? Do we already have evidence about it? Asymptomatic transmission.
I think at this point, all the literature that we've read, I don't know about if there's anything recent that Mario might have come across, is that there really has not been very strong evidence of frank asymptomatic transmission. Meaning to say, you're asymptomatic, you have the virus, you're not doing anything, and someone sits beside you, and then you transmit it. No? So it's likely still that there may still be some, let's say we said that there's fomite transmission, lalo na the hands, no? So if any infected surface might have been, or any surface might have been infected by the asymptomatic individual through his hands, from his face, his eyes, his nose, his mouth, then maybe an ehem or any factor or procedure that might have caused some droplet spread, no? Then that might be possible. But I've not come across any large study really that said that yes, asymptomatic transmission is very, very efficient. No, it has to have still some. Again, so it's close contacts with other people and some movement. No, can you let's say you might not have any symptoms, but if you laugh out loud, probably, maybe, because again, there might be some droplet spread in that event. We'll say asymptomatic, you don't have fever, you don't have a sore throat, you don't have a cough, you don't have a cold. No, but when we do have sustained community transmission, it's presumed that you can really get infected in the setting of many asymptomatics working with you. But I think it's still primarily from the environment and contact, no? Rather than a frank transmission by just, coming into direct contact without manipulation of the respiratory or the eye or the stools or anything like that, or you're not carrying it in your hands, then it's not likely.
Okay. If my question po dito, if for example there were already the rapid antibody tests are now validated, for example, we already have validated them and they are okay, no? When do you think it's the best? When do you think in the best time to use it?
Sa akin yung tinatanong ba? Okay.
To both of you po, to both our panelists. Yes.
Sige, si Rina na muna.
Yes,
Okay.
Dr. Racolayco.
If we did have a validated test, I think it would be a big help really in breaking quarantine, for all our patients who were admitted for some symptom at one point or as a suspect, or at one point turned out positive and just remained positive and asymptomatic already at a certain point, especially for healthcare workers, because there have been quite a number of healthcare workers who turned out positive that did not really manifest with symptoms. So they were generally asymptomatic. So I think at that point, these validated RDTs may be helpful. Also for determining in the community, and this is the study that I think Mario will be initiating, he'll probably discuss it, is really determining also the degree of immunity in the community, as far as determining, let's say, herd immunity and all of that. So what about for work purposes? Can you use it? If you really had a validated test, then, and you say, well, the sensitivity and the specificity is pretty high, then yes, you can probably use it for, let's say, return to work. But I would still stand with with compromise that if you are not symptomatic, no, then a rapid test that shows you an IgM positive, then do the PCR still. Because based on that, I wouldn't say, okay, huwag ka muna magtrabaho based only on that. Kasi wala naman siya symptoms. So for return to work purposes, if it were truly validated, only if you probably had an IgG, or if you had the IgM, then you get to test still with the PCR.
Mm. Okay. Um, someone asked here, wait lang ha. Actually, may nagtanong pa ho about PhilHealth, no? So later siguro mag-aano pa ako diyan. Later ko na siya ipopost ang question. So I'll just go on with the flow. So from the asymptomatic to the symptomatic patients, no? And with the testing. Will it give false positive result, RT-PCR, for those patients with who received flu vaccines or immunodeficiency illnesses like lupus? Well, is there a possibility to give false positive results in these patients tested for COVID-19?
Mario.
Parang wala. Parang
wala.
so far.
Actually, it's highly specific.
Yeah.
And
False
therefore,
positive. False positive.
False positive hindi hindi talaga. It's highly specific. False negative can happen primarily because of the swabbing techniques, because of the specimens that are submitted, and that's the reason why some patients kahit na severe illness na nag-negative pa rin, and that's the reason why we recommend doing a repeat PCR, particularly among individuals with COVID-19 or those manifesting similarly to a COVID-19 patient. No? So, yung false positive is unlikely. Now, baka ang worry na nagtanong niyan, kasi bakit yung iba na nag-negative na nagiging false positive pa uli?
Yeah.
Remember what I said, no? Yung fragments nga, which I think was also the theory or the reason why WHO came out with that statement about lifting the transmission-based precautions, because some patients may, in fact, have repeated positive results, yet they are no longer infectious, no? Primarily because this could be just fragments of the virus and no longer an infectious virus. No? So basically, yung false positivity misconception yan, just have to know how to interpret the results. And again, if we're asking for a repeat, no, particularly in the evaluation of our patients, just have to make sure that they are not or still shedding the virus. But again, in most reports kasi, sinabi rin sa WHO nga, after 9 days, narinig ko na rin kasi dati pa. More than 9 days talaga, the possibility of individuals still being infected is very, very low, despite, of course, the repeated PCR positivity.
Okay, thank you. All right, may question. Dami nating questions actually din. So anuhin ko lang ito ha. So is the PSMID guidelines in congruence with the PCS guidelines? I'm not sure what's the nature of the question, but I think this is in terms of aerosolizing mga AGPs, mga aerosolizing generating procedures. Currently kasi the WHO just stated na only stated yung mga particular AGPs or aerosolizing generating procedures through respiratory droplets. But how about other procedures such as electrocautery, mga ganyan, or for example, parang may isang concern din dito na questions about doing frozen section intraoperatively, parang ganyan. So, do we consider this as part of AGPs din po, as a part doon sa mga usual na AGPs na alam po natin via respiratory route?
Claro, Dr. Chito Salud, the current PCS president, actually vibered me a message about a concern. In fact, he commended us for coming out with the extensive guidelines, particularly on surgical procedures. Ang concern lang niya kasi is, of course, the categorization, whether it's low risk or high risk. And of course, when the procedure is considered low risk, we recommended, of course, ordinary surgical mask. that can be used. Of course, these are for non-urgent or non-emergency, more elective, and then asymptomatic, or even if there is symptoms but negative PCR test, tapos low risk yung procedure, surgical mask na nakalagay doon sa guidelines. So that was actually the concern raised by Chito and also by Ida Lim, by the way, na biniber din sa akin. Kasi ang concern nila, if they're wearing mask and yet yung kasama nila sa room naka full PPE, for example, yung mga anesthesiologists naman. And if this, for example, is not truly negative, no? Nagkataon lang yung negative yung PCR and yet symptomatic nga. Tapos naka full PPE yung anesthesiologist, sila hindi. So, na-expose sila dun sa gamit ng mga anesthesiologists o yung mga damit-damit sa gamit na nandun. And then kung surgical mask din lang naman nila, baka naman magkaroon pala sila ng sakit. So I think that was raised. And the good thing about the comment by Chito is that, of course, the offer of collaboration. And definitely I recommended it. And this is going to be discussed, or is going to be discussed tonight sa board meeting, because the concern is valid. Certainly the risk of getting it is still there. Despite, of course, categorizing it as a low-risk procedure, and certainly we still have to consider the possible risk of getting infected from other sources, not necessarily from the patient, but even for the other, the PPEs, for example, ng mga anesthesiologists na kasama nila sa room. Remember that these anesthesiologists are working around, moving around, and therefore they can be potentially contaminated. That can be discussed, and of course there are still lots of concerns, not only from the surgeons in terms of the guidelines that we release along with PHICS. I think Rina has an idea, of course, on some.
Okay. Okay, let me see if I still have, kasi kinokolate ko na lang yung mga questions na similar so that hindi ko sila tanongin pa ulit-ulit. So I'm just, kino-cohort ko yung mga nature of questions na meron tayo dito sa atin.
Yung mga naunang tanong before this session?
Yes, sir. Actually, I already asked that a while ago. So that is regarding asymptomatic carriers, no? And then another question about the nature of the virus, no? Sabi nilang ganyan, is there a possibility that it will recur just like flu, that it can have the potential to mutate? Or sabihin natin that it can for example a reinfection, parang ganyan at this time.
Yung reinfection at this time is not possible, primarily because certainly yung ni-report kasi na iba-ibang strains, no, but still the same. Remember, diba, mayroon pang mga strains na kaya dinedevelop na ng vaccine now can actually address all those. But getting reinfected by this SARS-CoV is not yet documented or not going to be possible. Primarily because yung mutation of yung fear factor kasi natin, because it can be similar to flu. Diba? Ang flu kasi lagi may antigenic shift, antigenic drift that can occur anytime. But this antigenic shift or mutation itself can really happen if, again, through the animals. Remember that this actually came from animals. And if another coronavirus, again, para combined, no, with another coronavirus, and this will mutate, and if they they infect humans, then that's another strain. But this is another strain, not the same SARS-CoV-2. And that again can happen, not maybe soon, because of the primarily agricultural setting dito sa Southeast Asia or sa Asia. And certainly I'm not predicting, no, kasi posible naman manggaling naman sa China. But that's the risk that we have to know, or we have to learn, and I hope that soon, again, if they develop the vaccine, this can target not only the current SARS-CoV, but even the other coronavirus infections. So it can be similar to flu, but right now reinfection is not possible.
Okay. How about other modalities, Dr. Panaligan? Like, for example, like we have these investigational drugs, but other treatments such as low molecular weight heparin or steroids or others like when do they have benefit for patients with COVID infection?
Yung low molecular heparin, yung binanggit ko kanina, it is actually recommended by WHO to prevent venous thromboembolism. No? So that's part of the adjunctive measures, primarily because in COVID-19 disease, there is some degree of hypercoagulability, and there is more atherothrombosis that happens. And that's primarily the reason why many, of course, would also present with neurologic manifestations. I read that there are around 1/3 of patients manifesting with dizziness and headache, and some, of course, will present with stroke, even hemorrhage, not just ischemic. No? And I think there's also a report of Guillain-Barré, no? Although we don't know if it really related to COVID-19. But so enoxaparin can work to prevent the complications related to COVID-19. Now, you mentioned steroids. WHO did not recommend it, particularly for COVID pneumonia. But I know that there are some doctors, especially in St. Luke's where we work, especially in extreme cases because of the cytokine storm. There could be a role, but you don't need, or you should not give it for a longer period. You actually choose, of course, the narrower spectrum, and of course, you give it just for 2 or 3 days maximum. So that you can somehow control, of course, the hyperinflammatory state that can happen. Remember that there is massive release of interleukins, cytokines related to COVID-19. Now, for the others like vitamin C, zinc, and melatonin, these have been being used. But if you will go to, I'll promote again our PSMID website. There's a rapid reviews. They have listed down there all the adjunctive therapies and all the evidences, the review, and you will see that there is really no evidence or insufficient evidence for us to even consider using this drug. They also included the plasma or the convalescent plasma, but even up to now, although we're using it primarily because it can work, there's still insufficient evidence that it is beneficial.
Okay. Dr. Racolayco, maraming po nagtatanong about reusing of N95. Actually, maraming nagtanong, Doc. Pero in general, parang they're asking if how many times can we reuse N95 and how can we, any ways of parang disinfecting it for them to reuse the N95 since medyo mahal siya and medyo hindi masyadong available ang N95 around.
Okay. As we mentioned, reusing the N95 is not the ideal. You can use extended use would still be the better option. However, many institutions are in fact looking at reusing it because medyo mahal. And we're talking about the 3M95 N95, the one of 3M. Some have looked. If you look at the latest, when was it released, Claro? Yung sa PSMID on return to clinic, sa clinic guideline, the 27, I think, or something like that. So, there is the annex there, the reusing of and reprocessing of PPEs. And there was also a study mentioned there on the reuse or the reprocessing of your N95s using UV lights, using peracetic acid chambers, and the efficacy that was adequated to them. And I know Makati Med has also initiated some of those studies. I think PMC as well. So yes, they are looking at the efficacy of using, I think, the peracetic hydrogen peroxide chambers for such, or even the UV lights. However, there is a protocol that is to be followed for the adequate use of that. How long can you use it? How long can you use, let's say, an extended, if you wanted to use it extendedly, as we earlier mentioned. So extended use would mean using it for the duration of using your COVID patients within the same day or within the same shift, and maybe giving some protection with a surgical mask on top of that or a face shield on top of that. But once it is soiled, deformed, dented, then it's best to just discard that. So is there an actual date? I would say usually as best practice in some hospitals, 48 hours, not more than that. No. However, that's not a continuous use. That means you've used it intermittently and kept it properly packaged it, properly hung it up in a receptacle, with its shape intact. No, then probably that would be the best. I don't. Other than that, reprocessing might be the next step if you had those the yung mga plasma chambers and plasma sterilizers or the parasitic acid machines, no, for such an event. UV, some reports kasi mention that UV light actually can destroy the how do you call it, the ionic matrix of the mask. But again, in that study, the one that was cited anyway in the annex, it did show some efficacy, no, for the use of UV reprocessing.
Okay, thank you, Dr. I have two parang questions left na lang, no. So one is regarding for healthcare workers, no, for those who kasi recommendation natin is parang at least every 3 weeks of being tested, and then those who become positive and then are asymptomatic, what will be the decision for them to be discharged and return to work, especially that these are healthcare workers, because there are some situations wherein after 14 days still positive. Do we advise them to return to work even if they are asymptomatic, or do we have to wait them for be negative for them to return to work even though they are asymptomatic already, gaya nung sinabi nung sa WHO recommendations? Dr. Panaligan?
Yeah. Of course, we can adhere, no, to the WHO guidelines, but of course we just have to present it first to the DOH so that it can be applied to all. No? Kasi it's not easy to recommend it now, primarily because baka hindi rin i-accept ng bawat hospital na hindi naman kasi adhered o hindi pa aligned, no? Sorry, hindi pa aligned sa sinasabi ng DOH. Baka pati yung taga-LGU, yung mga CESO, RESO, yung mga city health officers, pagalitan pa tayo, ba't tayo nagkiklear when in fact wala pa sa guidelines nila. So everything has to be properly coordinated. But I think it's correct for us to consider giving clearance even for those patients with positive PCR, for as long as they are asymptomatic and for as long as they still practice infection control. Yes. I cannot forget what I said to one of our colleagues, no, who has remained positive even for 2 months. No? Kakakulit niya kasi, to be honest, nabubwisit na siya kasi hindi siya makabalik sa work niya. No? Big time consultant to. And therefore, sabi, nung nag-IgG positive siya and yet PCR positive pa rin siya, sabi ko, that can actually already indicate, no, you're protected kasi may IgG na. And there's a level, no, and this actually being done in, of course, alam na natin St. Luke's, no, para tayo na St. Luke's. And therefore, sabi ko, that can already indicate protection. And therefore, you can actually, I would allow you to go back to work for as long as you wear mask, no?
Yes.
For as long as you still continue working with appropriate infection control measures. No? I do have the guts of telling that to him kasi gustong-gusto na kasi bumalik eh. But of course, the biggest problem is kahit sabihin na natin non-infectious virus yun, pag nalaman kasi ng mga ibang tao, ay, naklear ni Panaligan yan, no? Ngayon nakabalik na, positive pa yan. Di kakalat pa siya. But again, if you can adhere to what has been mentioned by WHO, knowing that based on the cohorts of patients, based on observations that many, despite being positive, they may no longer infectious because they're just fragments, then we can go ahead with the clearance for as long as we continue observing the proper infection control measures. Kaya yung last slide ko kanina, di ba? Avoid complacency. Yun yung lecture ko. Avoid complacency in infection control primarily because you don't want this to spread and you don't want to transmit anything, regardless whether you're talking about other respiratory viruses or infections. Kasi basta importante lagi tayo maingat.
Okay. Okay, so
I think sa PhilHealth, yung PhilHealth.
Yeah, actually may dalawang nature.
Nakita ko sa PhilHealth, nakita ko kasi yung tanong.
Yeah. About the PhilHealth, parang may dalawang question dito, but I think this can be clustered into one type, into one question na parang, what will be the PhilHealth stand on patient admitted and diagnosed based on symptoms only, but negative on testing? So I think ito yung mga parang clinically na parang or probable.
Probable COVID, yeah.
And at the same time, will the PhilHealth also include the expenses na based on their, if they have other comorbidities, will it be shouldered then, or will they cover lang do sa COVID alone lang na condition ng patient?
Ang pagkakaalam ko diyan, pag probable COVID, no? Pag probable COVID and you are able to write down sa CF4, di ba meron nang ni-require ang PhilHealth na CF4 or CF, ano ba tawag doon? Basta yung nandun yung clinical database and you are able to explain why it is clinically compatible with COVID-19 and you label as probable COVID, I think they will still, no, reimburse or give, of course, the amount, no, amounting to around 750,000 of this critical case of COVID, no. And then yung other comorbids na kasama doon, basta yung laging nakasulat doon yung pinaka major, di ba, yung COVID-19 kaya siya namatay. But the others, I think they can still be shouldered individually by PhilHealth, no. So, but ang alam ko talaga, yung probable COVID, i-cover yan.
I-cover yan, oo. Yes, agree. But I think they already released lang na parang the exact diagnosis that you should follow para magkaroon ng coverage for the PhilHealth. So,
yeah, pinabalik sa akin yung yung pinabalik sa akin. Kahit minsan lang yun, pinabalik sa akin kasi mali Kasi nakasulat acute respiratory failure secondary to COVID-19 critical.
Yeah.
So, dapat daw, sabi ko nga, mali nga talaga. Kasi, of course, dapat inuuna yung COVID-19 critical para
right.
lahat.
Marami siyang qualifiers marami siyang exact diagnosis na hinihingi para magkaroon ka ng coverage for the PhilHealth. So the other comorbidities may also be covered, yan. And yes, so PhilHealth will cover, pero you should have this diagnosis lang na nire-require nila. Okay, I think we already covered the aspects ng ating, so we already covered questions sa healthcare workers, return to work, infection control in the clinic, rapid antibody testing, treatment, okay, and the WHO guidelines, updated guidelines. I think in the interest of time, that will already cover everything now for our questions. Yes, Doctora.
Sorry, one last lang. I wanted to ask, there was a question on the Abaca mask.
Yeah, the Abaca mask.
The Abaca mask, and I don't know my opinion on that. Because it was recently, I don't know if Mario has one, because it's it's DOST recommended.
Endorsed, yes.
Yes. So, and I think it's with the same principles probably of a cloth mask or a surgical mask, keeping the infection to yourself and not spreading it. But as for protecting you against others, I'm not too sure. I have no idea the data on that. I don't know if Mario already has one or some of that.
Parang they claim, Doctora, that it's 7 times more effective in filtering parang ganun. Yeah. But then ako di ko alam. Parang I just read it 2 days ago from Facebook.
That would be interesting, diba? If it were,
we can actually look at the evidence if there is. And then certainly, if we see an evidence or we can actually conduct a study, then that will be good.
Yeah.
Make sure that it really works. No? But I agree that it can be similar to even an ordinary face mask. That it can protect others from you if you have the disease. Parang ganun siya principle niyan. But not really to be able to protect you, especially if you're not properly wearing it. No? Kasi ang crucial dyan, kahit sa N95, di ba, dapat may fit pa nga yan.
Yes,
so
right.
Hindi yan basta-basta sinusot lang. And then I think, I'm not sure if Rina mentioned about the problem with the K95.
Korean 95.
Korean 95. Korean 95. Kasi may problem yan sa fit That's basically the problem. That's a problem, di ba? Kaya ang hirap mag-rely sa gano'n pag may problema sa fit. And therefore, just be careful again. If I have to emphasize one thing, just continue precautionary measures. regardless whether it's COVID-19 or not, basta importante para makaiwas sa sakit, lagi lang mag-ingat following the basic concepts of infection control.
Okay. Dr. Acolaico, Dr. Panaligan, thank you very much for your time, for giving us your insights and answering the questions from our viewers. And Dr. Irastorza. Ay, wala na ano na si sir. Dr. Irastorza, anything you want to say? Ay, Dr. Kate Panganiban, what about the feedback form? How are they going to go about this webinar feedback form?
They can just scan the QR code flashed on their screen through their phone's camera, and it will direct them to the link. We will also send them a direct link through their emails for feedback. Thank you.
Okay. Last words from Dr. Irastorza.
Well, would like to thank the speakers, Dr. Panaligan and Dr. Aiko, and also to our expert moderator.
Wow.
And also to all the alumni who have attended, and also non-alumni. We have already expanded our webinars to not just cater to our alumni, but also to all the other doctors out there who would want to get more information about the COVID situation here in the Philippines. And also, we'd like to thank the Telemedicine Network of the Philippines for providing us the platform, as well as for Kay Panganiban for facilitating this platform for us. So thank you very much.
Okay, thank you very much. Thank you very much to everyone who attended this webinar series, and we hope to see you soon or next time pag meron na ulit tayong bagong webinar, di ba, Dr. Irastorza?
Yes,
next time
we
si Clara
plan to
na
have this.
speaker.
Oh, si Clara. Wait, Clara na speaker.
Thank you very much, everyone. Alvin, thank you very much. And Doc Jeffrey is also here po with us, the
Diyan
president.
pala si Jeff.
Yes, sir, the president of the TNP. Thank you, sir, for joining.
Jeff, thank you very much, Jeff, again. Thank you for this platform.
Okay, so I guess that ends our webinar for now. Thank you everyone. God bless. Have a safe night ahead.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Ang galing ni Kay, galing-galing.
Hi, sir.
Pwede na, Doc. Pwede ka na.
Punong-puno yung ano.
Yeah, I know. Congrats, ha?
Thank you rin, sir. Alvin, thank you
Thank
again.
you,
Oh,
Hi, Doc.
Apo. Doc Jeff,